السلام عليكم، مساكم الله بالخير متابعين حساب About Dentistry. أنا سعيد بتواجدي معكم اليوم. أحب أشكر القائمين على هذا الحساب لدعوتي. My name is Dr. Hytham Fageeh. I'm a consultant in periodontics and implant dentistry at Mina Clinics. Today I will cover the topic of aesthetic crown lengthening and the management of gummy smiles and excessive gingival display in general. Please feel free to ask me any question you like. You can either send me a text message on the side or a direct video, and I'll be more than happy to answer them for you. So I'm sure most of you had a patient who visited him or visited you and told you that, I'm not happy about my smile. I think there's a lot of pink that's showing and I'd like you to treat me. Or you've had a patient who visited your clinic who had been previously treated by a dentist through some kind of gingival procedure. Tissue rebound occurred, they're not satisfied with the treatment, and they want you to start all over. And based on my limited experience with this, and after asking many of my students, I find there's a big confusion between the two terms, gingivectomy and crown lengthening. When do you remove bone? When do you remove tissue only? So I'm gonna cover some basic things that you need to know, some general terms and anatomical concepts that are very, very important. So the first term, which I think is very important, is osteotectomy. Any removal of bone that is part of the attachment apparatus where you have periodontal ligament and surrounding the tooth is called osteotectomy, where you're cutting the supporting bone. While osteoplasty is actually the reshaping of the bone that is not part of the attachment apparatus. These two terms are very important, so you have to know the difference between an osteotectomy and an osteoplasty. So, and if you remember from dental school, the crown size that is visible to us in the patient's mouth is called the clinical crown, okay? If you raise the flap and you look at the whole tooth side, that's called the anatomical crown. So any crown lengthening or clinical crown lengthening is a procedure that is used to increase the size of the clinical crown. So anything you see visually in the patient's mouth. Two other terms that are important, active eruption and passive eruption. So during the process of eruption of the tooth, which we call the occlusal movement of the tooth, okay, that is called active eruption. But when the two teeth meet during growth, okay, the gingiva and the bone recedes to a level beyond or lower than the CEJ. That is called passive eruption. In some patients, that process stops, okay? The bone and the gingiva fail to recede below the CEJ. And I'm sure you've heard the term delayed passive eruption. In that case, you're going to see crowns that appear very small in size because the gingiva and the bone fail to recede to its normal position. So the bone is a very high level at the CEJ. That term is very important. You have to know this, delayed passive eruption. So after knowing those terms, there is a very important anatomical consideration. As a dental student or a practicing dentist, I'm sure that you've probably seen this picture like a million times, but there's a very important thing that you have to be very aware of. If you notice, from the bottom of the gingival sulcus to the crest of the bone, okay, Gargiulo in 1967 found that this dimension is constant in human beings. This dimension, the range of this dimension is about 2.04 millimeters. So you're talking about a distance of about 2 millimeters from the bottom of the sulcus to the crest of the bone. In every human being, no matter what the tooth is, either in the anterior, premolars or molars, you will always have that constant dimension, okay? This dimension or this structure is called the biologic width. So if the biologic width is about 2 millimeters, where you have 1 millimeter of epithelium and 1 millimeter of connective tissue, you will add another millimeter of sulcus and of healthy gingiva. So the distance between the tip of the gingiva to the crest of the bone is averagely between 3 and 4 millimeters, okay? You have to know that because if you're performing any kind of aesthetic crown lengthening procedure, you have to determine where the bone is going to be. Another important concept is the 5 mm rule. So what is the 5 mm rule? Well, this is a very important rule that was first discovered and published by Tarnow in 1992. And he said that the distance between the crest of the bone and the interproximal contact, if it is 5 mm, 100% of the time you will have a full papilla, okay? That percentage is reduced when this distance increases, okay? So if you maintain a distance between the crest of the bone and the interproximal contact point of 5 mm, you will always have a full papilla, okay? And I'm sure you've seen, a lot of cases where you have black triangles, okay? Because this distance has been increased, okay? Now, you have to remember that the anterior maxilla, or the lower anterior mandible, the topography of bone, okay, maintains a positive architecture. And when we say positive architecture, that means the interproximal bone is always higher than the radicular bone. It's never the opposite way around. So this structure is called positive structure. In the posterior areas, the bone becomes a little bit more flatter, okay? And if you notice here, you never want to expose the furcation areas. So you always have to evaluate that when you're doing crown lengthening, okay? So these are the basic osseous architecture terminologies. You have a positive architecture, you have a flat architecture, and you have a negative architecture. You don't want to have a negative architecture, okay? Because you want to maintain the interproximal tissue at their respective levels. So, another thing you need to remember is that lower anterior teeth or the upper maxillary teeth have an anatomical feature that you have to be very careful about. This is called a dishaescence, and if you can see until where it extends, and this is called a fenestration. About 6% of teeth will have dishaescences. This is more common in the lower anterior area. Fenestrations are more common in the maxillary anterior area. Determining these defects prior to any kind of surgery is very, very critical, okay? You don't want to remove any tissue, okay, or open flaps when you have dishaescences, since this might accentuate the problem and create even bigger problems, okay? So how do you detect them? How do you determine them? Well, fenestrations are kind of difficult, but dishaescences, I think you can determine them very easily if you do proper bone sounding, and I will show you how we do that further in our snaps. So, in addition to knowing all those basic concepts, okay, there are factors that you have to consider, local factors that you have to consider before performing aesthetic crown lengthening. One of those is crown to root ratio, and you usually determine that based on a radiograph. I think the second most important factor that you have to consider is the presence of keratinized gingiva, because that will determine your treatment approach, and we'll talk about that later. You have to determine where are you working. Are you in the anterior aesthetic area, in the aesthetic zone, or are you doing crown lengthening for functional reasons in the posterior area? You have to consider the root prominence, okay? Is this going to cause resorption or not? So in terms of indications, when do you say this case is indicated for an aesthetic crown lengthening, and when do you say no, this is a contraindication? Your first indication for an aesthetic crown lengthening is the presence of short clinical crowns, okay? This is a very common thing we do in dentistry. We usually remove the crowns, or if you have sound teeth, we open a flap and we reduce the bone so we can increase the length, okay? And you can see that the positive architecture is maintained and the presence of furcation is not violated at all. Okay, so another indication is altered passive eruption. And just like we said before, these usually have short clinical crown appearances. The gingiva and the bone has failed to recede, and this is why you have this appearance. Okay, this is a common indication of aesthetic crown lengthening. The third indication is excessive incisal wear. You can see this patient has totally abraded her teeth. The CEJ is at the normal level. The bone is about 3 millimeters away, okay, but the short tooth size is due to excessive incisal wear. So we usually can perform crown lengthening procedures, and we can open this bite prosthodontically. Okay, another fourth indication, which is very, very common, The prevalence of this is about 13% of females. Okay, 6% of males are affected by the presence of a gummy smile. Okay, this is another indication for crown lengthening and management of gummy smiles in the form of lip repositioning and so forth. So, another very, very common indication for crown lengthening is addressing the presence of subgingival margins. I'm sure you've seen a lot of cases like this, where a dentist has placed the crown but invaded the biological space. He went into that 2 millimeter area with his crown margins, and the patient started developing inflammation in this area, and it's continuously bleeding despite multiple sessions of scaling and root planning. It never resolves. There's a continuous inflammation because the body wants to resorb the bone and recreate that 2 millimeter dimension. If you see a case like this, the only indication is to take the bone down to its normal position, okay, and recreate that biologic width. So if you can see, the crown margin is right at the level of the bone, okay? We have to recreate that biologic width and create positive architecture to have a very healthy gingiva. For example of the case, if you can see, there's very minimal distance between the crown margin and the bone level. So we have to recreate that distance, okay? Recreate the biological width to avoid any problems in the future. So, my contraindications for not performing a crown lengthening are multiple. My first reason to not do it is when I have a poor crown to root ratio. That's one reason. 2, when my patient has very poor oral hygiene. 3, when I see advanced bone loss, okay, excessive periodontal disease and severe periodontal disease in the area. If I know my patient is not going to be compliant with therapy, if I see the presence of a furcation involvement around molars or premolars, probably you're going to have questionable and hopeless prognosis of this tooth. So you have to consider these things. You just don't go and you rush into treatment without taking all of these factors into consideration. Okay, so how do I approach my cases? Usually I look at the case. I talk to the patient and we have a normal conversation, and I try to determine the etiology behind it. If you cannot determine the etiology, do not approach the case, okay? If you have a case of excessive gingival display and the patient is complaining of a gummy smile, determine, you have to locate the reason behind it. And based on this reason, you're going to have a different treatment approach, okay? So what is the etiology behind excessive gingival display? Why does this happen? One of them, we discussed this earlier, is altered or delayed passive eruption, okay? Another reason is excessive bony maxillary excess, okay? The patient has excessive growth of the maxilla. Conditions that cause gingival enlargement, this is probably rare. A deficient short maxillary lip, excessive mobility of the maxillary lip, and last but not least, altered. Now, when I look at the patient, okay, I have to assess the equal thirds of the face. If the middle part is much larger than the 2 other thirds, I start thinking about vertical maxillary excess, okay? This is probably due to growth of the maxilla, okay? And if you have bony maxillary excess, try to assess with your periodontal probe. How much do you have? Do you have 2 to 4 millimeters? Okay, then do crown lengthening and maybe a little bit of Botox as a temporary treatment. Okay, if you have 4 to 8 millimeters, you're gonna do some lip repositioning or orthognathic surgeries. You have 8 millimeters, you're probably going to refer to a maxillofacial surgeon, okay? If the reason behind that is vertical maxillary excess, okay? The second etiological factor might be because the patient has excessive mobility of the lip. The muscles, the orofacial muscles are very strong, and because they smile, they give you a dynamic smile, they show an excessive amount of gingiva. So look at the patient. This is the static smile, okay? This is the smile we usually see in portraits, okay? But when you joke with them, you see a dynamic smile, okay? You have to measure the difference using a probe between the static and dynamic smile, okay? If you notice that you have probably 1 to 3 millimeters difference between the static and dynamic, I prefer doing lip repositioning. Okay, that's where we take the mucosa a little bit lower. If you have 2 to 4 millimeters, I take 8 to 12 millimeters of mucosa to reposition the lip. Okay, and more than 7, we need to take a big chunk of tissue just to bring the whole. So once you're done with extraoral examination to rule out the other etiological reasons of excessive gingival display, it's time to move inside the patient's mouth. Okay, by looking at a case like this, it is very obvious that the dimensions of teeth are not within normal range. Okay, I like to assess the amount of keratinized gingiva I have. I like to then determine the dimensions of the teeth. And the third important step, I need to know where my CEJ is, okay? You cannot treat a case like this by just taking a knife or a laser and trying to increase the tooth size without knowing where the CEJ is. So, I have to determine my CEJ before I determine the bone level. If you can feel the CEJ with an explorer, okay, that means the short tooth size you're seeing is because of incisal wear. If there is no CEJ, that means the CEJ is below the bone and you have a short crown, okay? You immediately make a diagnosis as altered passive eruption. So the next logical step is to perform bone sounding. Is that clear? Bone sounding. Believe it or not, I think this is like the most important thing in any kind of crown lengthening procedure you're going to do, either in the aesthetic zone or in the posterior region. You have to perform bone sounding. If you cannot determine its location, you cannot classify the type of treatment you will do. Okay, if your bone is very close to the CEJ and you perform a gingivectomy, that tissue is going to grow back. Your patient's going to come back, or he's going to come to me or to another dentist and he's going to say, you know, my treatment failed and I'm not happy. Okay, because the treatment choice was not chosen based on the level of bone. So you have to perform bone sounding. I like to use this tool from Hytham. Okay, it has 3 marks, 1, 2, and 3. 3 is like the normal distance to the bone. Okay, so if you put the gingiva right here, the bone crest should be at 3 millimeters. Okay, so once you've determined the level of the bone, the next step is to determine the exact and appropriate size of the crown. Okay, this patient has altered passive eruption. So what is his normal tooth size? I highly recommend buying this beautiful gauge. It's called the proportion gauge by Stephen Chu. In Saudi Arabia, the dealer is a Turkey medical group. Okay, this is it. You know, it's very nice and very easy to understand. You see the average size of, or the width of a central is about 8.5. It automatically collaborates with about 11 millimeters in height. So the end of the red lines here will match the end of the red line here. This is a beautiful golden proportion for a central incisor. Okay, so you can use this either on your cast models or directly on your patients to assess tooth size. You have concepts of digital dentistry. If you don't want to do that, this is the best choice. Done, you've determined your actual tooth normal size. Okay, you like the way it looks on the cast, on the wax up, on the patient, you're happy with it. It's time to classify the type of altered passive eruption you have so you can provide the exact correct therapy. So, a question for you guys. Let's assume the distance between the crest and the bone is 5 millimeters, okay? And we have a lot of keratinized gingiva. That means the biologic width here is normal. There is an excessive dimensional area. So the treatment of choice for a case like this is gingivectomy, okay? This case is classified as 1A, okay? And the best treatment option is gingivectomy. Never forget that. We know what 1A is. What is 1B? 1B is you have a lot of keratinized gingiva, okay? So you can shape the way your crown looks like. But the bone is very close, okay? This distance is reduced. So this is classified as 1B. You have adequate keratinized gingiva, but the crest is at the level of the CEJ. You have to recreate the biologic width. So the best treatment approach here is a gingivectomy, and you have to open a flap and reduce the bone level, okay? If you cut the tissue through a gingivectomy, what will happen is your body wants to, or the body wants to recreate that biological width. So you're gonna have rebound in the tissue. Okay, this is when your patients come back complaining, you know, it's just like where we started, nothing happened. Okay, and the reason is because that dimension has not been modified. A third scenario, okay, is the patient has altered passive eruption. We made that diagnosis, but there's no keratinized gingiva and you want to increase the tooth size. Do you just take a laser or a knife and you start increasing the tooth dimension? Okay, this is very critical. You have to know the classification. In this case, you know, the bone is far away, probably more than 5 millimeters, but there's no keratinized gingiva. If you remove that keratinized gingiva, you're only going to have alveolar mucosa, okay? That's going to cause a lot of problems for your patient. So the only way to increase the tooth size is to bring the tissue down through an apically positioned flap, okay? Okay, a fourth scenario, the bone is at the CEJ. There is no keratinized gingiva at all. What am I going to do? How are you going to increase the tooth size? The only way you have is you have to open a flap, reduce the level of the bone to create that biologic width and bring everything down. You don't need to perform a gingivectomy, okay? This case is classified as 2B, okay? There is no enough keratinized gingiva, and the bone level is at the crest of the CJ. So you're going to do sulcular incision, reflect the flap, reduce the level of the bone, and bring it back, okay? So you're going to do an apically positioned flap plus osseous resective treatment. To best explain this, I'll show you on one of my cases, okay? This is a case referred to from my prosthodontist, Dr. Abdullah Mishni. And if you can see, the teeth look kind of ugly, they're square, okay? So I want to know where the bone level is, okay? So based on some bone sounding, you can notice that the distance is 5 millimeters. I have enough keratinized gingiva, so the right classification is 1A. And based on that classification, how am I going to increase or perform an aesthetic crown lengthening? Okay? I know because this distance is greater than 3 millimeters, I can basically or simply treat this through a gingivectomy. And in this case, I used a diode laser, a 5-watt diode laser, and we remove the temporary crowns, and there you go. This is your final restorations. Okay, so no flap was done. I can expect that this case will... If you're going to perform a gingivectomy, your case is 1A, okay? You're not going to use a diode laser. The easiest way to do that is you can create a bleeding point of where you want your anticipated gingival margin to be. I like to use a 15 blade, okay? And I perform a 45-degree incision. This is called the external bevel incision, okay? Then we smoothen the tissue out, but do not forget that you have to perform scaling and polishing to avoid any rebound in the tissue. So here's another case. We have very good keratinized gingiva. We have a very thick biotype, but the teeth are not within their normal proportion. They're kind of square and they're flat. So I like to bring my tooth proportion gauge, okay, and I determine the actual size on a cast, okay. In this case, when we did bone sounding, the level of the bone was very close. So if you perform a gingivectomy, okay, what's going to happen is the tissue is going to go back. It's going to rebound like you haven't done anything. So since this case is a 1B, the best treatment is to perform a gingivectomy, open a flap, reduce the level of the bone so you can perform osseous resection. Okay, this is the cast, so we draw it out to our technician. Okay, he waxes up the normal dimension that I want. I use a surgical template, okay, with a diode laser. I remove the tissue, okay, and then the next step is I open a full thickness flap, okay, and from this new crown margin, okay, the normal distance should be 3 millimeters, 1 millimeter of sulcus, 1 millimeter of connective tissue, and 1 millimeter of epithelium, okay? And this is the final result where we have very good long-term stability, okay? So you have to classify. Just don't go, rush into therapy, treating everything with the laser. That's the only solution you have, okay? You have to perform bone sounding. And if you notice, I'm stressing this a lot, but it really makes a huge difference when you approach these cases based on Kozlett's classification for altered passive eruption. So first step, again, we determine the level of the bone. Okay, this is very close bone, so this is 1B because we have enough kg. Okay, the normal dimension of the tooth is recreated using a diode laser. Okay, so the treatment approach for 1B is a gingivectomy and osseous reduction. A full thickness flap is elevated, and 3 millimeter is created to establish the biologic width from the anticipated crown margin. Okay, this is an end cutting burr. You'll find it with Al-Qusaybi. The company is called Brasler. Very beautiful burr. I would recommend that you have a few in your own armamentarium. Okay, the whole bone and an osteoplasty is performed, and the flap is sutured back to its normal position, and you can expect very good long-term stability right here. So in order to summarize aesthetic crown lengthening and the management of gummy smiles, I'd like to show you this case. Imagine this case sits right in front of you on the chair and tells you I'm not happy with my excessive gingival display. So the first step I do is I like to determine, is it part of the 5 etiological reasons I have to exclude? Okay, and based on that, I perform my therapy. In this case, the patient had equal thirds of the face, so vertical maxillary excess was ruled out. Okay, she appears to have, very short clinical crowns, so I'm suspecting that there's altered passive eruption. I try to locate the level of the CEJ. Okay, it's below the bone. Okay, there's enough kg. Okay, so I immediately make a diagnosis that the excessive gingival display is due to altered passive eruption. So I perform bone sounding. So I use my beautiful gauge, okay, and on the cast, I determine the normal tooth size of where I want to be. You can do this using digital smile design, okay? Personally, I can't afford that kind of software, but I can do it very easily using this beautiful tool, okay? So you can either do it the fancy way, the digital way, or you can do it the way it has been done for multiple years. Okay, so that's a tip. I hope you take use of it and use this tool. So the next step, I take some PAs. Okay, and if you notice, the crown, the CEJ of the crown is below the level of the crest. So this confirms my diagnosis that this is a 1B case. You can see from the side, the dimensions of the teeth are completely off. And this is where I want, or how much. So we performed a gingivectomy, and I elevated the flap, I reduced the level of the bone, and you reach a beautiful conclusion like this. Your patient is happy, I'm happy, and everyone has a beautiful day. Thank you very much for following me on About Dentistry. Follow me on my account if you have any questions about periodontics, or an implant dentistry, tooth recession, sinus augmentations, bone grafting, all that kind of cool stuff. Follow me on my account. Feel free to ask me. I'm very happy to have had this opportunity to talk about this topic. Thank you very much, and I wish you guys all the best. So, if you enjoyed these snaps and would like the opportunity to perform a hands-on workshop on aesthetic crown lengthening on animal heads, and you want to see a live patient, Mina Academy is going to have a series of courses starting on April. You can follow me on my account. You'll see the flyers for these courses. You can come and join us for one day, meet our consultants at Mina Clinics. We're going to have courses on porcelain laminated veneers, surgical crown lengthening for the general practitioner. We're going to have a laser certification course. This is super cool. I'm very excited about that. We're going to have rotary courses or courses in endodontics on rotary instrumentations. Follow my account for more information. We'd love to see you here at Mina Academy. To follow our clinics, I'll leave a post, and would love to see you on Instagram too.